would like to begin by acknowledging that the University of Alberta is located on Treaty 6 territory and respects the histories, languages, and cultures of the First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich all of our
Right.
vibrant
Thank you.
communities. I would also like to thank Paladin for their generous support, ongoing support for the ATI seminar series. I have been asked to remind everybody to mark your calendars for December 2nd of this year, that in Calgary, there will be a Gardner Symposium on Pediatric Transplantation. The registration link will be provided kindly through SIDEA and the ATI. It is my real pleasure this afternoon to introduce my colleague, Dr. Blaire Anderson. So Blaire is a hepatobiliary, pancreatic, and multi-organ transplant surgeon at the University of Alberta Hospital and an assistant professor at the University of Alberta. Blaire was a general surgery resident here at the University of Alberta, and then went on to complete her HPB Association accreditation through her fellowship at the University of Washington in St. Louis, and subsequently her American Society of Transplant Surgeons accredited fellowship at the University of Nebraska in Omaha. Blaire's research interests include liver transplantation for oncology indications, living donor transplantation, and gender disparities in surgery. I'd like to welcome Blaire on her topic of the seminar today on intestinal and multivisceral transplantation. Thank you.
So thank you for the kind introduction. I'm going to talk a little bit about my experience and my training in multivisceral transplant, and then our experience here at the University of Alberta. There isn't a lot because this is a fairly rare transplant organ group. So to start with, I don't talking about any medications off label. Being a surgeon, that's a little easier to do. So we're going to discuss intestinal failure and understand the indications for intestinal transplant. We will review outcomes in both adult and pediatric patients worldwide, and discuss organ allocation and its challenges for these types of transplants specifically. So intestinal failure is failure of digestion and absorption. So really it's a loss or absence of area for those purposes. And at the end of the day, it results in inability of the GI or intestinal tract to maintain adequate nutritional status, including fluid and electrolyte balance. So the ESPN categorizational failure really is characterized by the duration of the intestinal failure. So short-term intestinal failure is kind of those patients who come into hospital, they're malnourished, maybe had an operation, aren't able to eat for a period of time. And so they need some nutritional support for short term, really, less than 3 weeks is the definition. Type 2 are the patients who need a longer duration of support, usually in the number of weeks to months. And these are, when I think about these types of patients, it's the patients who have GI fistulas. They can be treated surgically and potentially come off TPN. And within the US, this is about 8 to 9 million patients. The patients who need long-term nutritional support are those who have chronic conditions. They're metabolically stable with this support. But they do require IV supplementation over many months or years. And realistically, their problem may be reversible or it may be irreversible. So really, the intestine can't get longer. And in the US, this is about. So when I think about transplant, and this is Dave Mercer, who trained me in Nebraska, transplant is really what you do, and what you have just isn't enough. So we need to get you new stuff. Everything other than that is considered rehabilitation. So what you have isn't perfect, but it's not terrible. And let's see what we can do to try and get you to that end goal using what you have. And transplant and intestinal rehabilitation should really work together. And we should strive to make transplant unnecessary. So intestinal failure management or intestinal rehabilitation really is multidisciplinary. The goal is to support adequate nutrition, minimize complications of getting that nutrition, and ideally achieve enteral autonomy. Medically, we can talk about things like intestinal adaptation and growth factors. And I don't claim to be an expert in this. You all really are the experts. So this is sort of a sampling of some of the work out of our institution. So we've come a long way in terms of line care. We used to just replace lines when we had line issues, and ultimately we would lose line access. But now we know that repairing lines is just as good, and we have found ways to preserve lines and prevent bacterial infections. TPN lipid profile has changed dramatically and is much kinder to the liver. And then growth factors really have revolutionized the management of these patients, and lots of patients do really well with this. So this is the intestinal rehabilitation team that taught me in Nebraska. And like I said, the goal is really to support these patients. It is multidisciplinary. And surgically, there are some things that can be done. We can maximize every bit of absorptive capacity that these patients have. So this may mean reestablishing bowel continuity in patients who have high or proximal stomas or fistulas, maybe mean repairing these fistulas, providing access for enteral nutrition in the form of gastrotomy tubes or gastrojejunectomy tubes, and then bowel lengthening procedures to both improve motility, enhance absorption, and then limit bacterial overgrowth. So I know a little bit more about this from my training. So dilated bowel really is not functional. If you think about a wide pipe and you're squeezing sort of the walls of the pipe, everything in the middle isn't going to move. So really leads to dysmotility, and then at the end of the day, intestinal overgrowth. So we talk about length, but diameter really is just as important. And these diagrams sort of show different ways to maximize both the function by narrowing a dilated portion of bowel, and as well lengthen bowel by doing these serial transverse enteroplasty procedures where you lengthen and narrow this really dilated non-functional bowel. So this is a case series from Nebraska where they did repeated procedures, the narrowing procedure that both lengthens and narrows. And with this, they were able to deal with redilation. So after a step procedure, that bowel dilates again. And they, at the end of the day, were able to sort of wean more kids off of parenteral nutrition and remove lines. So sort of durable weaning of support. So intestinal rehabilitation program, really, we optimize everything medically. We try to optimize everything surgically. On TPN, you kind of have to ask, how's that going for you? If you're on TPN and life is okay, you can kind of do all the things you want to do, and you're not suffering ill effects, then really you're a winner. So circling back to this, so transplant, what you have just isn't enough. We need to get you new stuff. Everything other than that, rehabilitation, and they really should work together. Doing these multi-organ transplants. This is a picture of him bringing back organs in a plane. It's sort of the beginnings of transplant. And then one day it's you. So this is me as a fellow going to LA to recover. This was an isolated intestine, bringing it back to Nebraska and then sewing it in with actually a bunch of people from Edmonton in Nebraska. This is Shahid Marani and Dave Mercer in the picture on the bottom of the screen. So really you're standing on the shoulder of giants. So it's really interesting to think about the lineage of how you've trained. And it kind of all comes back to Starzl in the United States anyway. So total multivisceral abdominal transplant concepts really started in the 1960s in animal models. As I mentioned, Tom Starzl was one of the first to attempt or do this, and Richard Lillehei was sort of simultaneously doing this work. So in the 1980s, there were attempts in humans. Postoperative hemorrhage was a big problem. The following two patients developed post-transplant lymphoproliferative disorder, and they never left the hospital. The first hospital discharge of a patient who received a multi-organ transplant was in 1989. That patient survived for 10 months without parenteral support and ultimately passed away from metastatic pancreatic cancer. So within Canada, and then in Grant performed the first successful liver and intestinal transplant. And here in Edmonton in 2003, Dr. Bigham did the first intestinal. So we've always sort of been pioneers and leaders in this field here in Edmonton. So deciding which patients would benefit from intestinal transplant really is an ethical and clinical dilemma. Most patients do well on TPN now, is particularly compared to 10 or 20 years ago.
Culture so far is
very safe with decreased complications. But 10 to 15% of these patients don't do well. So these are the that we need to be thinking about for. So when to transplant? Really, it's when the chances of maintaining life long-term on TPN are diminishing. So you have to be ready to accept a finite death or mortality rate with really a 1 in 5 chance of dying in 5 years with multi-organ transplant. So when you're thinking about, is this the right decision, you have to ask, is the chance of not being transplanted and dying more or less than that? So when patients have liver failure associated with their parenteral nutrition, the decision is a little bit easier to make because we know that the long-term survival with liver failure is not there, and that it's a little easier to swallow the risk of mortality from an organ transplant, multi-organ transplant. So ESPIN refers to liver injury because of one or more factors relating to intestinal failure, including but not limited to parenteral nutrition, occurring in the absence of other liver pathology, other hepatotoxic factors, or biliary obstruction. And we're seeing less and less of this, but we still do see this. So intestinal transplant, what are the pros? What are the cons? So the positives, so we replace the normal intestinal anatomy. Patients are able to eat and drink normally. Ideally, they have no more parenteral nutrition and the problems that are associated with that. We can reverse liver injury or replace a diseased liver. But then what are we weighing that against? What are the cons? So there are risks of major surgery, risks of rejection, probably more so than other organs that we're used to dealing with anyway, the liver alone. And then risks of lifelong immunosuppression. So infections, cancers, renal failure, graft versus host disease due to the large lymphoid burden that comes with the bowel. So what are the indications? So this is the latest report from the intestinal transplant database. So in pediatrics, short gut composes 63% of these patients, and gastroschisis is the most common cause of short gut in these patients. Volvulus, atresias, neck, ischemia, these make up a small portion. Separate from short gut, motility disorders contribute to 18% of indications, and then malabsorption 8%. Tumors 1%, and there are some other things and retransplant as well that make up these indications. So indications for transplant for multivisceral or intestine alone. Really, if we can't give parenteral nutrition anymore, we've lost our central access, or we're down to our last line, for example. This is an indication because we won't be able to feed these people anymore through their lines if we can't get them in. Multiple infections of their parenteral lines is another one. So 2 episodes yearly or a single episode of fungemia is considered an indication. And then organ dysfunction secondary to parenteral nutrition. So most commonly, this is the liver in multivisceral transplant. Separate from nutrition, frequent dehydration in the setting of concurrent PN and IV fluids is considered another potential indication. So this paper looked at sort of, can we better define indications and make them standardized? And this was an international multi-center study of the Toronto listing criteria. Edmonton contributed to this study, Nebraska contributed to this study, as well as some centers in the UK. It was retrospective, a study of 443 patients with intestinal failure. The primary outcome was death or intestinal transplant. So 40 patients, or 9% of the patients, did die. 53 or 12% were transplanted, and 11 died post-transplant, so 20% of the transplanted patients. 45% did not achieve enteral autonomy, and they were able to validate this criteria as having high predictive value of who did need a transplant. So this was more than 3 of 6 access sites lost, so losing options for central lines for nutrition. More than 2 ICU admissions, and most of these were for infection, but also some for dehydration and kidney injury. And then persistent liver issues. And then they were able to say, similar to what I mentioned in the last slide, these patients are the ones that would benefit from transplant, as they're starting to have more and more issues with continuing parenteral nutrition. So trends in intestinal failure through time. So again, a retrospective analysis. And this really looked at the rates of patients staying on their parenteral IV nutrition versus transplantation. And this showed that the rates of death in transplant in children with intestinal failure have decreased. And this was mostly likely due to all the improvements we've made in terms of the line sepsis and line access and what we're feeding these kids through their IVs. The number achieving enteral autonomy hasn't really changed. 31% remained parenteral nutrition dependent, but these patients were living longer with fewer complications. So transplant and rehab really should work together. So we look at the adult population. So short gut, again, is the main indication for this transplant, but now we're looking at ischemic insults as the reason for losing their intestine. Crohn's contributes to about 11% of the indications, trauma 7%, volvulus 8%. 13% were transplanted for tumor, and we'll talk about a little bit about indications for this. Motility disorder makes up 11%, similar to in children. So what are potential oncologic indications for multivisceral transplant? So there's several reports from the UK and more recently some reports in the United States for transplanting patients with stomachsoma peritonei. And what is that? So that's a very rare appendiceal tumor, sometimes termed jelly belly, where if the appendix perforates with this tumor and this is spilled, they can have disease everywhere in the abdomen with time. Active surgery and high PEC. But even with this, they often will have recurrent disease. And so if we take everything out, does that improve their outcomes? And so this is being done with sort of short-term outcomes favorable. Neuroendocrine tumors is another indication in adults. So often these small bowel neuroendocrine tumors involve the root and the mesentery, and there's really no way to get all of the disease out without taking the blood supply to the intestinal tract. Additionally, these tumors do metastasize to the liver. So if we take everything out, are we going to have better outcome when this tumor is quite indolent, and people who don't have surgery do have a sort of a long-term survival with other treatments. So this was a sort of a systematic review looking at of those patients being transplanted for neuroendocrine tumors, because we do sometimes transplant liver alone for this indication. Is multivisceral being done? And yes, it is, but it does make up a small number of those transplanted for neuroendocrine tumors. So separate from oncology, what about diffuse portomesenteric thrombosis? So these are patients who have clot within the portal system down to the SMV, which drains the entire small bowel. These patients often will have portal hypertension with potential for life-threatening variceal bleeds, but because of the anatomy, liver transplant often is not possible because we have nothing to sew the portal vein of the new liver to. So this was a small series of 5 patients, but they sort of tried to define when should transplant play into the treatment for patients with this problem. So if there is a different way to recanalize the portal vein, so get flow to the liver, this is preferable. But if not, if shunt isn't possible, either radiologically or surgically, then this is an indication for multivisceral transplant. They did report the outcomes of their 5 patients, and there were significant complications associated with this. So this is why transplant should be reserved for those patients where there really aren't other options. They had other organ failure requiring, for example, renal transplant, They had issues with their vessels requiring repeat operation and repeat vascular reconstruction to the graft. So significant complications are definitely, unfortunately, part of this procedure. But patients who do get through the postoperative course do quite well. So what does sort of the volume look like worldwide? So this was a report of global activity and trends from the Intestinal Transplant Registry. And as you can see in the beginning, things were very slow, outcomes were dismal. But with time in select specialized centers, outcomes did improve. Transplant activity really did peak sort of in the early 2000s. And since then, and this sort of does correlate to when TPN became kinder to the liver, and we learned more how to deal with lines. Transplant activity has decreased, and this is because intestinal rehabilitation has improved so much. But really the climb was sort of centralizing this to high volume centers. So in the United States, there's been about 3,900 intestinal transplants in the history. There really are only 20 centers who do these transplants. And only 4 that train fellows. So Miami, Nebraska, Georgetown, and Cleveland Clinic are sort of the big volume centers in the United States who do train fellows. So it is really a specialized operation because there aren't a lot of places doing it, which is for the better. So within North America, you can see that the activity has increased, and likewise across the rest of the world. But it sort of seems to be plateauing, and probably for good reason, because intestinal rehabilitation is so much better than it used to be. So this looked at sort of intestinal transplant alone, so putting only the small bowel into a patient, and then that compared to multivisceral. So what are the volumes like with time? So multivisceral being more than one organ, so intestine with liver, intestine with liver and pancreas. And I'll talk a little bit about these differences in a couple slides here. So this showed that sort of we are maybe doing more isolated small bowel transplants, which may eventually lead to worse long-term graft survival, but it's a little bit easier to just take out an intestine if there's issues going on in terms of rejection or leaks or things like that. And then you always do have multivisceral transplant as a sort of a next step option. So what are the outcomes like? So in this sample, survival rates at 1 year are reported at 7%, 5 years, 50%, and at 4 years. And for intestine alone, the short-term outcomes are better, but it really does sort of level out when you look at the longer-term outcomes. So 1 year survival for intestine alone is 86% compared to 75% for multivisceral. But at 5 years, it's 61% for intestine and 58% for multivisceral. So with time, things really do level out. And this probably has to do with the immunogenic component of the intestine alone. The liver really does have some protective value in that sense. So now I've talked a lot about it. So what am I talking about when I say intestine versus multivisceral? So intestine is when we transplant the small bowel, plus or minus colon. And we have to sew the arterial drainage to the aorta, and the venous drainage usually actually is to the portal system, not the vena cava as shown it's just the intestine. Multivisceral transplant involves the hepatobiliary system, so the liver, the bile ducts, the pancreatico-duodenal complex, so the pancreas and first part of the intestine, stomach often as well, and then the intestine and colon. So in other words, any organ that relies on the SMA or celiac artery for blood supply. So some operative pictures. This is explanting organs that aren't good. So you can kind of see it's like a big mat of intestine. You can't really make out what's colon and what's small bowel and what's what. Everything's just sort of stuck together. This is in a patient who's had multiple previous surgeries for resection for small bowel, neck, and perforations, and really has not a lot of intestine left. So this is what we took out. So the liver is there. You can see sort of on the left side of the screen, the pancreas in the middle, and then whatever was left of the GI tract on the right, but really just looks like a big clump of badness. This is a liver coming out. Sometimes we take things out in portions. So the liver, and then here you can see there's really just a big open cavity, the diaphragm on the top. We have some sutures ready to go to sew the vena cava drainage of the liver in. This is the graft. So the arterial supply to the whole graft comes from the aorta. The SMA and celiac are branches off of this. So we prepare the aorta, the thoracic aorta, to use as our conduit. And this is preparing that for transplant. And here you can see when it's all done, all of the lumbar arteries are tied off, and we have a long piece of vessel to sew into the recipient. Here we're taking the spleen off of the donor organ. So the pancreas is sort of heading towards the top of the screen in the middle. The arterial graft is kind of coming outwards. You can see all the little ties on it. And we're removing the spleen from the pancreas, as the spleen is not transplanted. Here we're sewing the organs in. So this is the upper vena cava, just below the diaphragm. We sew that to the vena cava of the liver graft. And then here we're sewing the arterial conduit for the inflow to the organs. In Nebraska, where I trained, we used an extension graft from the thoracic, the graft there. Here in Edmonton, we just use the aorta in continuity and sew that to the recipient aorta. So this is the aorta in a pediatric recipient. It's very small, but bigger than vessels we're used to sewing with livers alone. So here you can see after reperfusion, you have a nice healthy pink bowel. The liver looks beautiful. The conduit is right next to the surgeon's finger there, and it looks full and good blood flow going through, obviously, with the nice pink bowel. So these transplants do require ideal donors. So in general, we cannot use donors after a DCD or donation after circulatory death. It's too hard on the bowel, and we really can't take that risk with perforation and ischemia in a graft. Intestine donors should be young, ideally under the age of 40. They should not require high doses or multiple pressors, as we worry about what this does to the bowel. And we know from ICU patients that this can cause issues in patients who are on high doses of pressors. And donors should not have an ileus. We want to know that the bowel is going to function. For pancreas, the donor BMI should be less than 30. The donor should not have history of pancreatitis or diabetes. The size should be about less than 2/3 of the recipient. And this is because a lot of these patients have had multiple bowel resections, and they really don't have much in terms of abdominal domain. So you just want to know that the organs are going to fit. So in the United States, they've moved towards these acuity. So they look at distance from the donor hospital as a means to sort of allocate organs in a regional manner. So they look at sort of priority within first 150 nautical miles, then 250 nautical miles, and then 500 nautical miles. So remember, we just talked about ideal donors. So liver intestine combination donors are offered to liver alone first, with very high MELD, because we know these patients will die without organs, whereas the multivisceral patients are a little bit more stable. So this in general is patients with MELDs greater than 29 for liver. Ultimately, the liver intestine combinations do play up higher in the sort of allocation, and so you are able to get ideal organs, and organs are usually close, so your ischemic time is usually favorable. So there was sort of an analysis of how the new acuity centers impacted transplant and multivisceral candidates. And what they found was that adult multivisceral candidates did have significantly lower transplant probability and trended towards higher mortality. And this did lead to some sort of changes in how the acuity circles worked and exception points for intestinal patients. So now pediatrics are automatically provided an additional 23 MELD or PELD points on MELD or PELD to give them priority. In adults, they now use a median MELD at transplant, just sort of to equalize, which is one of the higher, or almost highest additional exception points. And the goal is really to get above a MELD of 29, which is the threshold for liver intestine combinations. This does preclude any candidates who are listed for a liver transplant solely for immunologic purposes. So they really do need the liver because of liver failure from TPN, for example. So within Canada, we do have a way to prioritize for our pediatric patients, as there really are few pediatric donors, particularly when we're looking for smaller donors than our recipients. So pediatric patients requiring a combined liver and small bowel, terminology is multivisceral, they are given 3F prioritization, unless their calculated MELD is greater than 35. So if they're very sick, they obviously don't need much more prioritization. In these cases, a mandatory discussion between centers with 3F and 3LS patients is required. And then 3P is just the very small patients, pediatric patients weighing less than or equal to 6 kilos. In adults, they're listed based on their natural MELD without really any organ sharing between centers. So we are a bit more limited in the graphs that come up for our adult patients who are listed. So circling back to Nebraska, sort of some lessons that I learned while I was there. So in Nebraska, they did almost always include some colon in their graft, particularly if the recipient did not have any colon. And the reason was just mostly for fluid balance and what impact that had on the patient's kidneys long term. So we know these patients are on calcineurin inhibitors, and those are hard on the kidneys long term. And a lot of times our recipients of these organs are very young. So if on top of that, they have issues with absorption and hydration status, that could really have a big impact on kidneys. So they would include donor colon. And with that, they found that they had a higher rate of ileostomy reversal and that it was protective to the patient's kidneys. There was initially some concern about including the colon, and as it was previously thought to be associated with more rejection and graft loss and infection. This did not hold true in our series. So the next one was looking at DSA. So we know that multivisceral patients do have higher rates of rejection compared to liver alone, for example. So can we find that rejection sooner? So in the beginning, we do protocolized biopsies of the intestine weekly, just so that we can catch these things early. But is there any ability to use just a blood test to know this? So with the serial biopsies, they were collecting their DSA levels. And patients who had post-transplant DSAs, they maybe did have a shorter time to diagnosing rejection with biopsy because it prompted biopsy when they wouldn't have otherwise needed a biopsy. But it is very time-consuming, costly, and I don't know that this is standard of care. And we aren't really using this here yet. If we know someone has high DSAs, we do have a lower threshold to biopsy, but do we need to be repeatedly checking DSAs? I think we're still not really sure. So then line access. So in Nebraska, they had really phenomenal interventional radiologists who could get lines into really almost anyone, and they had some pretty unique ways of putting lines in. So they would sometimes put lines transhepatically, so access the hepatic veins and wire a line up kind of reverse from that way. They could sometimes, even once they had access from below, they were able to sort of drill through any stenosis and get lines proximally. We do know that transhepatic lines have a higher rate of infection, a risk of being dislodged, leading to intraperitoneal bleeding, and they're not really useful for multivisceral transplant candidates intraoperatively because the liver is removed in explant. But if we're trying to get people through just intestinal rehabilitation and we've lost access, this may be potentially another option with some advanced training. So what about in our program? So since 2003, we've done 39 multivisceral transplants, both pediatric and adults. And this is just a sampling of some of the post-transplant patients sort of living life, swimming, riding their bikes, going to school, fishing trips, just really like good quality of life for these young kids. So in our program, starting in 2003 was a busy year. There were 3 transplants then. On average, we're doing about 1 or 2 a year. But in the last 4 or 5 years, the volume has picked up a little bit. We did 5 in 2021, 4 the following year, and then 3 the 2 subsequent years. So what are we transplanting for? So in pediatrics, short gut is the primary indication. And within this, gastroschisis is the main indication. Motility issues account for about 20%, tumor 5%, and portomesenteric thrombus 5%. In adults, mesenteric thrombus and short gut both account for about 39% of transplants. Tumors 6%, motility 5%, and then other indications 11%. So we've done 20 pediatric multivisceral transplants, with the average age being 2.5 years. And then in adults, we've done 19 transplants. And again, these are young people, the average age about 39. Of our entire series, 23 patients are still alive. The average kind of post-graft survival was 6.9%. The range about 75 days to 21.7. Of the deceased, the average survival was about 2.4 years, and the range was about 3 days to 16 years. So in summary, for pediatrics, intestinal failure really should be managed in a multidisciplinary manner. We need to optimize everything medically, optimize everything surgically, optimize growth factors. If we're still on TPN, we need to ask sort of how's that going? And if quality of life is good, maybe that's what should continue. And if we start to run into issues, so line loss, ICU admissions for infection, or persistent liver issues, then transplant is a good option. But transplant and rehabilitation should really work together. Transplant comes with risks of major surgery, rejection, and lifelong immunosuppression. And the reported survival rates are 76% at 1 year, 56% at 5 year, and 43% at 10 years. So we really have to balance survival while on TPN versus survival of transplant. In adults, in general, the indications are different. There is potentially a role in oncology, desmoid tumors, neuroendocrine tumors, and pseudomyxoma peritonei. There is a role in portomesenteric thromboses, and we've done many of these in the last 5 years with good outcome. The risks are similar as they are in pediatrics. So risk of major surgery, risk of rejection, and risk of lifelong immunosuppression. So thank you again for having me. I'm happy to answer any questions.
You didn't comment on, Blaire, sometimes, of course, I come at this as a pediatric transplanter, but the size of our patient, at least in my world, the size of the patients influencing the choice of graft. Would you like to comment on that at all? And then Carlos has a question after that.
Sure, yeah. The size is more of an issue in pediatrics, mostly because of their indications, I think. These are small kids who've often lost their GI tract at a very young age, and so have not really had any opportunity for abdominal domain. So in general, we are looking at the weight of that. Sometimes we still have challenges in closing the abdomen. We have strategies to deal with that mesh, biologic mesh, different things, but sometimes it is an issue. We can't really just leave intestine with skin covering it. That would cause big issues. So size is a very is a barrier in pediatrics, particularly when we have few pediatric donors in our country. And I think in the recent past, several of our very small multivisceral grafts have come from the United States, simply because they have more donors and more pediatric donors. So it is definitely an issue, more so in children. In adults, these recipients have had opportunity to grow their abdominal domain, at least to some extent. The indications are a little different, so they may have their GI tract, but we're transplanting for clot burden. So it's a little bit less of an issue. But in kids, it's definitely a problem, and kids do wait a very long time on our list in Canada.
Thank you. Carlos, you have a question.
Hi, thanks for that great talk, Dr. Anderson. This is probably a classic type of question. Given the numbers, and this is probably an overall low number situation, do you see any strategy that as a hospital, as a province, we can do to increase more this number of multivisceral transplants?
Yeah, I mean, I think in general, I don't know this to be completely fact, but because we're in Edmonton, I think it's thought about a lot more in Edmonton. So potentially just awareness in other referring centers. Because these patients are very complex, they're generally already treated in a very specialized hospital. So it's not like we're looking for these particular patients in smaller towns or centers, but potentially just education about who could benefit, because there is likely some selective referral from our centers locally. I know in pediatrics there is a good sort of strategy to deal with this. So the Calgary team is always involved in our intestinal meetings, Saskatchewan as well. So I think the awareness within the pediatric world is very good, but within the adult world, separate from those patients who are potentially being referred for liver transplant and have portomesenteric thrombosis, those are probably being sent to us from all provinces. But patients who've had large bowel resections for Crohn's or on long-term TPN, say in Saskatchewan, may not know that this is an option as much. I know we do receive referrals from Saskatchewan and Calgary for adults, but I think that it's probably less. So awareness might be the best answer to your question, Carlos.
Thank you very much.
Any further questions for Dr. Anderson? I'm sure everyone knows how to get a hold of Blaire through the global AHS emails if there are any questions that will follow. I know there was some people who were running off to clinics and sent a thank you to you, Blaire.
I think
So
I see Oscar has his hand up.
Oh, okay.
Hi, Blaire. Thank you for the talk. Just a question. Do you have like any data on what are like the main mortality causes for that population? Or you
Yeah, I mean, there's data, but the indication is so variable that the causes of mortality often reflect the indication. I think technically one of the things we worry about the most is we're putting in a bowel with bacteria, we're taking out a bowel with bacteria, there's always spillage, and then we're sewing many vessels. So mycotic aneurysm is sort of the technical issue we worry about most in short term. That's probably the most common cause of more. Longer term, it's recurrent infection. So we're really always balancing infection and rejection. Long feels like, but in the short term, it's usually technical issues, and again, infection plays into it because mycotic aneurysms are very difficult to salvage if possible at all.